Um, okay, welcome all. Let's make a start. So today we have Dr. Tony James from Oxford, who will deliver a speech about psychopharmacological treatment for bipolar affective disorder, early onset bipolar. So Dr. James is a consultant adolescent psychiatrist at the most prestigious Highfield Psychiatric Inpatient Unit for Adolescents in Oxford, United Kingdom, and he is also an honorary senior lecturer at University of Oxford. So he has a long-standing experience of therapeutic and research work with adolescents, and he's undertaken longitudinal neuroimaging research and have been involved in setting up a collaborative research networks, including a multi-center international project in stem cell work. Dr. James has been involved with dialectical behavioral therapy service for adolescents since its inception over 12 years ago, and also audited and published outcomes of this project. He is an active collaborator in Enigma, which is a multinational imaging consortium in early onset psychosis, OCD, and laterality studies. His current interest is in treatment-resistant depression and adolescence. I must also emphasize that I worked with Dr. James at Oxford Highfield unit for around 14 months. So I am the first-hand witness of his extensive experience of psychopharmacology and other treatment facilities. Actually, I was at the Highfield when the DBT service was established. So it's all yours now, Dr. James.
Thank you very much indeed, and thank you very much indeed for inviting me to talk here. I was grateful for being able to talk yesterday, and as I said then, and I do repeat really in a way, that it's all very well for someone like me to come and talk later in their career, as it were, but the important thing about a conference is you really, is your youth, enthusiasm, and your future. So the important thing, I think, to remember is that questions are vital. Not just questions here, which I welcome and we can think and discuss, and if I do have some answers, then I'll surely share them with you. But the point being is that if you do get a question and it's not answered, and maybe that'll stimulate you to carry on research, because that's what it's all about. In fact, what I've learned is that I know now less than I did when I first started, and I think that might be true for you too. And that's, I think, a healthy sign. It's an interesting area, really, and hopefully we'll go through some of the findings that we have and some of the questions, but it is certainly a confused area. I think many people would agree with that. But there's been some consensus of late, but I'll take you back through some of the dilemmas that actually have dogged the field just a little bit. I think quite unhelpfully, but it's probably highlighted this area, which is an important area, and I'll show you some epidemiological research and the findings, and I want you to have a look at the findings just to share your thoughts. Okay. So if you do have questions along the way, then please do. We'll have some time at the end. But we have to finish at 1:45 because of prayers. It's Friday. Okay. So the important thing is we have to have a framework. And actually probably for bipolar disorder, this is extremely important, because without this, then we're going to go veering off into all kinds of areas, which I'll highlight later on in terms of differential diagnoses. But the important thing here is to remember that you do need for the DSM-5, which is 2013, but still our hallmark, increased inflated self-esteem and grandiosity. The rest we'll go through later on. But actually, when you see a manic or manic patient, then this readily comes to mind. But in adolescence, is that the only thing you need? Well, I do think you need this. Absolutely. That's what I look for when I'm doing an unstructured or a structured diagnosis, is to look for hallmarks. And actually, just sharing this with you, the best diagnostic instrument for making the diagnosis of bipolar disorder is pen and paper, pencil and paper. You do your diagram. Sorry, I haven't got it on the slide here. And what I usually draw is an axis, time along the bottom, and I actually draw my moods, which are fairly boring because I'm a kind of boring character. So it's not really much happens to me. Just Monday you might be a bit down, Friday a bit up, so kind of end of the weekend, beginning of the weekend, things like that. But actually they're pretty unremarkable. But actually, if you give the pen and paper to the patient and he or she truly talks, or this, you made the diagnosis. You don't really need anything else. A pen and paper, that's what you need. And you just scan that into the notes and you've got the diagnosis. So forget all about this case ads and all the rest of it. You've done it. Now, I would recommend this group here. And I know my colleague from Canada here would probably agree with that. But actually, I think this is a really well-crafted, well-researched, and referenced document. So I recommend this. It's easy to read, and it sets forward this. And what it says here, that there is a greater consensus in the field about developmental differences. And actually, this bugged us, the field, for several years, but I think they're right. We now agree that irritability on its own does not make a diagnosis of bipolar disorder in children. And we'll come to that. There's still some controversy about this, but actually, we should base it upon the same set of diagnostic criteria as they do for adults. So DSM-5 would be the area would be the document you need to go to. So we've half solved the problems for this talk. We might be able to finish a lot earlier. When you look at the DSM-5 criteria, look, high rates of symptomatic recovery and high rates of recurrence, though. And that's the important thing. And actually, I can tell you that the previous head of department, or previous but one now, in Oxford, Professor Guy Goodwin, and his successor, John Geddes, were bipolar disorder experts. This is the field that they worked in. And Guy Goodwin would always almost taunt me and say, you in adolescent psychiatry can't make the diagnosis of bipolar disorder. And why did he say that? Well, it's extremely difficult. And so that people would say, mood instability, yes, but basically it's family problems, relational problems, and things like that. And would not make the diagnosis until they suddenly come to Oxford University and they'd have a florid breakdown. And it would be clear going backwards that actually the diagnosis should have been made at the age of 15 and so on, things like that. So he would say, you just don't have enough knowledge or expertise to be able to make that diagnosis. And he's quite strident in that view. And I think it's very difficult. It's easier looking backwards than it is to look forwards, perhaps. But I do think in child and adolescent psychiatry, we need to be sharper in making that diagnosis. And here, there's a corollary of this, is that a lot of young people with adolescent onset bipolar disorder aren't treated. They're not recognized, and they're given psychodynamic treatment or non-supportive treatment and things like that, and that is entirely wrong. So hopefully during the day, during this morning, we can think about this and actually start making ourselves better and treating our young people more rationally. So what about the epidemiology and phenomenology? This is a very old study, but it is one of the hallmarks. If we go through it, way back when, 2003, So certainly recognition that bipolar disorder can, even Kraepelin suggested that you can, if you read his articles, not that I have in the original German, I'm only taking the transcript, I apologize for that, but he does talk about treating a child with bipolar disorder, so it's not that unusual. But actually under 19, very low rates, threshold obviously increased. This is just a follow-up here, but actually in this particular study, more females than males. But if we go to Van Meter, and this study has been criticized by Perry in Australia, and we'll come to this in a minute, suggesting that actually if you look across nations, this is one of the areas where cross-national studies actually do help, then actually what you look at here is a weighted average prevalence of 3.9%, which is across the whole group. So it doesn't seem to be that much more prevalent, say, in the United States versus Australia versus UK. So that's a very interesting finding. So pull rate there is bipolar 1 was 1.6%, which is quite low. And higher rates of bipolar disorder spectrum where you use broader criteria, older age, and lifetime prevalence. Newer studies were associated, and that's quite interesting, with lower rates. So actually, they use more defined criteria. But this study has been criticized because Perry from Australia said, if you actually look at the studies included in this and really scrutinize it, you'll find out that the prevalence of bipolar disorder in children was about 0, he maintains. And there's some truth in that. And here we have Koach, who actually cautions about making the diagnosis bipolar disorder in children and adolescents, because if you come in with a young child who has high elevated mood and mood instability, there's a possibility of differential diagnoses. And he was suggesting, yes, bipolar disorder, yes, certainly, but you do get mood swings, or do you? That's a question we'll come to in a minute. But certainly, one of the diagnoses here that's not included on here is borderline personality disorder type problems or emerging borderline personality, where emotional dysregulation is actually it's a hallmark. And the young person can come in rapidly changing mood, for sure, and quite disabling mood changes, but it's not bipolar disorder. And how does one know that? I think actually longitudinal, we'll come to the nice guidelines how one actually can make these diagnoses and actually offer a sensible proposition on this. Okay. So early detection is actually quite important, but as we've already shown, I've already said, that actually you can get mood swings here that are not necessarily bipolar disorder, so it's quite difficult to actually make a diagnosis here, and often a diagnosis is not bipolar disorder. And as I suggested to you, Professor Guy Goodwin, with a retrospectroscope, could actually criticize us for not making the diagnosis, but it's actually quite difficult. In fact, I put it to you, but here it becomes very clear. If I would suggest to you that this is not on the slide here, and I just want you to think about this for a moment. If you have young children, or you have brothers and sisters of 3 years old, and you frustrate them, or there's this frustration, and you have a temper tantrum, mood swings here, then actually, if you translated that up to a 15-year-old, you clearly would have a pathological scenario. And it well may be that actually, as you go from childhood to adolescence, the hallmark is regulation. So actually, instead of you get the behaviors more potentially driven by limbic associations, you get more frontal, prefrontal, medial prefrontal cortical control of your behavior, then actually these mood dysregulations become smoothed out. Now, what's the difference between ADHD, bipolar disorder, and borderline personality disorder? Well, it could be that's just some environmental, if you've got borderline personality disorder, very highly linked with abuse. But the others could be genetically linked. And we know ADHD and bipolar disorder from the work of Cardiff and so on, things like this, is actually very much, shows very much a great overlap. So it could be that actually the ultimate phenomenological output, ADHD, borderline personality disorder, or bipolar disorder, is actually possibly a genetic. And we're talking about a pathological process of a poorly regulated emotional regulation. Does this make sense? So we've got a complex area here. It's not so straightforward. Now, we did some work. Clacy is a colleague of mine, looking again at the cross-cultural aspects of this. And I'm sorry this is not in color, but believe you me, this, or take it for granted, this is US. Hospital admissions across different countries. So this was US. This, I believe, was Australia. And here are Germany and the UK. Complete surprise for Germany and UK to be actually aligned on certain things, but we are here. Even this was pre-Brexit, I've got to say. But what we find here is an extraordinary divergence in hospital admissions. Now, it's hospital admissions. I've already told you that epidemiological surveys in the community are pretty uniform across countries if you use standardized diagnostic criteria. But when you look at hospital admissions, then it's a completely different process. And here we have something that actually, by the age of 9, hospital admissions in the United States at that time exceeded all the cumulative admissions in the UK up to 19. So something's completely going wrong here. And this is the hallmark which I was able to answer the American reviewers when they first said, oh, it's just a UK, European take on things, got things wrong here. But actually, if you're an American young teenager at 15, you better watch out, because you'll very likely get admitted if you smoke drugs, have promiscuous sex, or whatever it is here, and a diagnosis bipolar is made. But actually, it drops by something like 30% by the age of 17. So, come on, there's no explanation for that except for diagnostic criteria that are slightly wrong. And here, looking at this over here, again, this emphasizes the point I made earlier, that actually by the age of 9 in the United States, the prevalence or the incidence of hospital admissions is greater than the UK, right through the total of childhood. Now, we've already told you the Canadian review group actually have said there's greatest consensus now. This, I think, was wrong. Everyone recognizes this. And I'll show you the figures, because it's quite interesting when you work with epidemiologists. But before we do that, and this is very important, because it's in terms of treatment. Everyone talks about the treatment for bipolar disorder, treatment of mania. Relatively straightforward to treat, well, not that straightforward, but it's not that difficult to treat manic episodes. I might have to swallow my words later on, because it can be extraordinarily difficult too. But on the whole, if you read about bipolar, the treatment of disorder first mentions mania, whereas in reality, it should actually be putting depression first, because not only is it the most difficult to treat, it's the least researched and actually the most common presentation, as you can see. This is the episodes. First, a group blue one is depressed, and you can still see that actually depression is the most common presentation of bipolar disorder. So that makes, again, diagnostically difficult, because if your first presentation is depression, maybe you just treat it as depression. So you give an antidepressant and actually make the course of the illness perhaps worse. Now, this is work by Anne Duffy, who works in, I think, Ottawa. Canada, who's a world expert upon pediatric bipolar disorder because she's followed up a cohort of children of parents who have bipolar disorder and treated with lithium. So she's very much to the forefront of this, and she's trying to expound really a staging process in bipolar disorder with because that is a model that's actually well suited for, say, psychosis. But if you look here, and I think this is important, is actually, all right, so we have the well child here. The first presentations may well not be a mood disorder, and it could well be anxiety, sleep disturbance, ADHD, or learning disabilities. But then, actually, you see here, you have sleep problems, then depressive and activated symptoms here. So it could be made a diagnosis of adjustment disorder or borderline personality disorder. I put it to you here, minor mood problems here, but then becomes a major mood disorder here with depression and sometimes psychotic symptoms. And we get then more easily in early adulthood a kind of presentation of bipolar disorder. So it's not surprising there's a world expert saying, look, the course is multifaceted. It's not straightforward. So I think Guy Goodwin, well, hey-ho, it's difficult. But this is quite an interesting slide because it shows, if you look at this genetic makeup, there does seem to be quite a different group here. There's an early onset, later onset, and a very late onset. And the later onset there might well be related to cerebral pathology. But there's possibility of differentiating the different types of bipolar disorder on a genetic basis. Now, this paper refers to Moreno, a paper that I and my colleagues did, but actually showing that the rates of bipolar disorder in outpatients and inpatients had increased quite dramatically. That's interesting. But I refer you to this one here. This is the hospital admissions, which I talked about earlier, for the UK. And this is the United States. And again, shows a dramatic fall from age 16 downwards. Now, when we went to Michael Goldacre, who's an epidemiologist, and we said, we've calculated the difference between UK, England actually, hospital admissions, because we have a national database, part of the NHS, and the UK. Now, the US is actually the veterans' hospitals. It's not the whole of the US, so it's not completely comparable, but it's the best we could do. And we said, actually, there's a difference of about 70-fold. And he said, oh, come on, this is ridiculous. You've got decimal point in the wrong place, because for an epidemiologist, something like 7 is major. I mean, that, if you've got a difference between two places of 7, that would be quite right. 70, you've just done your sums wrong. Please go away and come back. And he just dismissed us and threw us out the door. Well, he didn't throw us out the door. He's very polite, Oxford Don. But he just said, come back when you get sensible results. So we said, yeah, we did get it wrong. It was actually 73 times higher. What? And that is the case. But we're not comparing like with like, because if you look here, the median length of stay in an adolescent service in the United States for mania was 6 days. It's 34 days in the UK. So the difference in hospital systems, for a start off, and similarly for all these figures here. But it is not straightforward, because not only is the admission rates for bipolar disorder different, but you have to compare other systems too, and all other psychiatric disorders is considerably higher in the States than in the UK. And obviously, if I'm coming from the UK, I'm going to say, look, even in ADHD, I'm going to say, oh, well, everything's right in the UK and everything's rosy. It's completely not, because actually, in the moment, we've got COVID and God knows what else in the UK, and the NHS is struggling because actually the number of hospital beds we have is probably one of the lowest in Europe. I don't know, maybe even lower than Turkey, maybe the same, but I don't know. But we certainly, you cannot necessarily say a hallmark of the UK is right and therefore everything else is wrong. And it could be that we're just not emitting enough, and that's my contention, actually. It's not that the US is, well, the US, I think at this particular point, is clearly an outlier. There is no doubt about that. But whether we in the UK are emitting enough, that's an interesting question. Anyway, but this is a question for you future researchers. Well, not a question, it's a kind of warning. Don't rely on single or even data over 2 or 3 years because you could be misled. If you looked at this here from 2000, 2001, just published that, you'd say, oh, in the United States, the rate of admissions for bipolar disorder in this age group is increasing dramatically. No. Well, in this group here, it's definitely increasing dramatically. That's obvious. Well, it's decreasing here. And overall, it's completely level. So it's important to take as long of a group as you possibly can. I'm not a statistician, but I can tell you these 2 things. Take a long view if you possibly can, and have as large a group as you can have. And here, you can see there's absolutely no change whatsoever. So it's stable. Okay. Now, one of the differential diagnoses Kovacs talked about was a differentiation between ADHD and bipolar disorder. Of course, you can have both together, and I had to ask my colleague for treatment about that. We maybe can mention that in the discussion later on. So they certainly can co-occur, that's for sure. And the treatment is interesting because you can use stimulant medication even with those with bipolar disorder. But actually, this is quite an old study now, but actually it's quite interesting because if you look, the major difference is the important things. Remember we went through the DSM-5, the diagnostic criteria here, elevated mood? Not necessarily. Grandiosity? No. Flight of ideas. Now, Eric Taylor, who was my tutor and certainly a world expert in ADHD, kind of put a little scenario and about a child coming out, and it actually criticizes the Washington USAIDs for the diagnostic instrument used in the United States for making the diagnosis of bipolar disorder. But actually, if a child in a class comes up and says, I'm going to become Prime Minister or President of Canada or United States or something, that could be just useful exuberance. And actually, he or she might even become president and so on, things like that. That would surely be a sign of mental illness, but anyway, that's aside. But a child could be, in the wrong hands, that could be put down as grandiosity. No, I think that's normal. If, however, the child came up and said, I'm a very good teacher, I want to take over this class because I'm better at doing it than you are, then that's clearly not only grandiosity, but actually taken to the extreme and action follows and things like that. That is grandiosity. So you've got to be very careful in making grandiosity claims in children, because they could be normal exuberance, and that's where experience counts. Flight of ideas, no, you do not get them by ADHD. Decreased need for sleep, it's not, there may well be difficulty sleeping, but on the whole, that's not a hallmark of ADHD. But look at this, irritable mood, distractibility and increased energy, you cannot differentiate the 2 diagnostic groups on these symptoms. I'll just go back. This makes the point that you've got to take a broader range of symptoms to be able to make a clearer diagnosis. And of course, as I said, it's possible to make to have both diagnoses together. Now, actually, this is quite an interesting kind of thing. It's differential diagnosis. So here we have the symptoms of bipolar disorder, attention deficit here, and oppositional defiant disorder. I'm not quite so clear this really is a major diagnostic problem, but obviously some people might. I think where you get that is where you get irritability, dysfunction. The young person actually mood may seem unstable, because they're actually opposition on that particular point, but I think this is not really a major problem. I think the major problem for us at the moment, at least in the UK, is differentiation between that and emerging borderline personality disorder, where emotion dysregulation is absolutely a hallmark. It's important also to actually, when you're seeing the young person, to see the young person on their own. Do not ever make the diagnosis or try to make the diagnosis of the young person in the presence of a carer, parents or brother or sister, because there may well be even a patient who has bipolar disorder, so the patient has bipolar disorder, might well be more reserved about saying what their symptoms were and the problems were in front of their guardians and so on. And it's completely understandable. For instance, I had a young 17-year-old girl, and parents were saying this. Parents left the room, and she said, well, they don't know what I get up to. And what she used to do is very, very dangerous. In her higher moods, she'd climb out the window of her bedroom and actually get on a train. The parents were asleep in the house. They didn't know this. And she would go up and have sex with anyone she wanted to on the train, then come back in the morning and, hey, her parents didn't know anything about this. Extremely dangerous behavior, for sure. And the parents hadn't a clue about this. So that was clearly a great worry. The other thing is that actually, for the diagnosis of her disorder, again, the pen and paper were very helpful. Now, in Oxford, John Geddes and crew actually helped us with a thing called True Colours. Now, True Colours, and other places have different kind of systems, is a digital representation of mood disturbance. So you ask the person to fill in a chart on their smartphone. Everyone has a smartphone, so it's straightforward. If you don't know, you're not sure about the diagnosis, you can monitor over time. The person is given a text to actually fill in this 2 or 3 times a week, and they rate their mood and other associated symptoms. Now, I thought at the time, this is just nonsense. I couldn't see this being that helpful, but it's tremendously helpful for 2 reasons. One is, if I was to ask you, I'm not going to, but say if I was to ask you, what was your mood like 2 weeks ago on Tuesday? Well, if you're like me, it's pretty boring. I'd say it was pretty level. But actually, the chances of you being able to say what your mood was like 2 weeks ago on a Tuesday is virtually nil. You just make it up. So if you get a contemporaneous monitoring of this, it's very good. And actually, the results are text to you as a psychiatrist, to the GP, and to the patient. So you can then meet the patient in your outpatient clinic. You already have a review of their diagnostic, of their mood for the last thing. You can say, oh, what happened on that day? Well, I was smoking cannabis. Okay, so that's not really a very good idea. Or that day, well, we had school exams and so on, things like this. So you don't have to go through the retrospective history, which I've already indicated to you is totally unreliable. You can then actually look at the life events and say, what happened here? You missed your medication, and so on, things like that. So actually, I think that's terribly, terribly helpful. And there are many other systems that actually do use that. Now, the other question, I've already told you, this is practitioner's guide here, is the pen and paper. But the really interesting question is, from whom? From what group really helps you make the differentiation of mood disturbance compared to their peers? Answer? Ask their peers. Because the peers will be taking drugs or doing things in the middle of the night that you wouldn't dream of, or you wouldn't admit to dreaming of. And they act as the baseline. So if you ask the question, what did your peers think about you doing this? Oh, they thought I was crazy. Ah, that's very, very important, because you wiped out all the confounds there straight away, and above and beyond normal peer expectation, this person is presenting as crazy. And the peers walk away or say, you shouldn't do this. So that's a really helpful question. Now, you can't have the peers in your consulting room, but a simple hypothetical question, what would your peers say? And you get an answer. And that's, I think, terribly, terribly important. So it's a good tip. Pen and paper and asking that hypothetical question. They're not in the guidelines of books, but I think it's terribly helpful. Okay, you came here for treatment, so maybe we'll get on to that. Oh, there we are then. You know who I am. Now, do not fall into the trap of thinking the treatment of bipolar disorder is actually medication. It's medication plus psychoeducation plus the possibility of psychological help. And I think that forms the package that you need to offer. And I'm going to mention ECT here because, well, I mentioned it so we can dismiss it. It comes up later in a slide here, but I'm an advocate of ECT for very severe drug-resistant mania. If you have someone who hasn't responded to 4 treatments and actually 4 different medications and said, look, can we raise the dose or add in another? I can't work out the interactions between these drugs, and I don't think anyone can. And actually offering ECT, it has to be under an order of the Mental Health Act because the patient is not likely to be competent at that particular time. Is it successful? It is probably one of the most successful treatments I know in medicine. I had a patient, just an example, very much a Noel Coward person, wearing his dressing gown, telling me this, that, and the other, hadn't slept, as far as I know, for 3 weeks. We have now in our newer unit, a quieter suite. And it's actually there for disturbed, violent patients. But it works like a dream for 2 sets of patients. One, those with autism that can't tolerate the normal interactions within a ward, as you can imagine. So that's one group. The other group is those with bipolar disorder. And actually, just having quiet. Just quiet. And then someone bangs the door. That person's awake again. It's so difficult to get. Look, could you just not put your bleep on? This person hasn't slept for 2 days, and you come in and slam the door. But on this very quiet area, patients are able to settle. So if you had to ask for I did say earlier on that acute treatment of mania is not too difficult. Actually, I lied. It can be very, very difficult. But actually having quiet background and things like that is absolutely crucial. Getting back to the story, this Noel Coward character was a very nice guy, but actually was very disturbed. 3 weeks not sleeping, 3 treatments with ECT, completely back. Now, I would suggest to you that that's a good treatment. And I would suggest the treatment beforehand is potentially dangerous, if not lethal. So these are kind of questions. But there was a very interesting kind of thing because we have in the UK, as I suspect in the US and other places, I don't know about Turkey, an antipathy towards ECT, even though it's been shown to work. And I was phoned up by a Times journalist and suggesting that actually I was out of step with everyone else because I gave it, and it's only about once every 2 years, so it's not as if I'm giving it left, right, and center. But other centers in the UK had given none at all. So I don't know the answer to that at all, I suspect. Anyway, I'm not necessarily a huge advocate for ECT, but I do think it does need to be mentioned in this type of talk. But I'm sorry, I rather stupidly jumped from here to here. Let's go back here. So psychoeducation for the individual and family, absolutely crucial, because you want to put the patient in charge of their problems, and so they can take control. It might well feel they're out of control at the time. I actually say to patients with schizophrenia, bipolar disorder, eating disorders, anxiety and things like this, is at the moment, I'm sorry, you've got this illness. That's tough on you. It might be genetics, might be environmental, or whatever it is, but it's tough, you've got this problem. And I'm very clear about this. I make the diagnosis, you say, that's your problem, but you do not necessarily have to let your life be controlled by it. You need to take control of the illness, and that's where psychoeducation comes about, understanding and taking control of it. We have here then psychopharmacology. Will go through this. Neuroleptics, benzodiazepines is not used so much, I think that's right. Mood stabilizers. But the antipsychotics we do have now are a range: aripiprazole, risperidone, olanzapine, quetiapine, lorazepam. Lithium is a mood stabilizer. Sodium valproate. The evidence is not so great for that, but actually it's certainly not for adolescent girls. It's absolutely not, because of pregnancy difficulties and ovarian problems too. Lamotrigine, especially for those who have mood disturbance or depression. Carbamazepine, I don't use now. Basically, this is not. Oh, I'm sorry about this. I was part of the NICE guidelines. I think I mentioned yesterday when I was talking, National Institute of Clinical Excellence, because they are foremost, I think, in analysis of data, absolutely strictly rigorous in their approach, so that actually if a NICE guidelines recommend something, you know that's going to be really well-researched and there's no bias there. But actually looking at this, this is response medications versus placebo for acute mania. And actually you can see here, quetiapine, aripiprazole, risperidone, olanzapine, valproate. Well, that doesn't look like it's working. And overall, for the medications here, there's a clear benefit for medication versus placebo. Now, what you may not know about NICE guidelines, although I said it is very rigorous, there is a way around it for drug companies, is they ask for a technological assessment. And a technological assessment is for their drug versus others, but it does not at that time look at the totality. What I mean by that is the drug company, for both schizophrenia and for bipolar disorder, that manufacture aripiprazole, are extremely clever. They ask for a technological assessment about 6 months before the bipolar disorder group actually was set up. So they compared aripiprazole to all the other drugs, but what they didn't do was look at the other indications of those other drugs and how they worked against each other. Am I making sense on this? So actually, aripiprazole, if you look at the NICE guidelines, is highly endorsed because the technological assessment came up and showed, oh, it kind of works. But when you look here, it's not that great compared to quetiapine and olanzapine and so on. But the technological assessment had to go in the final bipolar disorder guidelines unaltered, because those are the guidelines. Even though we wrote to them and said, actually, when you look at the totality, aripiprazole is helpful, but it's not a prime thing. That's like trying to convert someone. It's impossible. So NICE is good, but it has a problem with the technological assessments. Well done for the manufacturers of aripiprazole. And just looking at the symptoms here for acute mania, the slide goes the other way, this time here favoring medication this way around. And aripiprazole, yes, it's there. And valproate. Here, now, did I not say that actually one of the big things in terms of the textbooks and the way we talk about bipolar disorder is everyone goes for the mania when they should be going for depression first, because that is the most prevalent disabling symptom and the most difficult to treat, I would contend. And the evidence, well, look at this. It's hopeless. There isn't much evidence there. This is dated now. I appreciate there's evidence from that. And actually what the NICE guidelines actually said for children and adolescents, as the Canadian group also said, you have to take evidence from the adult studies as well, because it just isn't sufficient for children and adolescents. That was actually quetiapine. Okay. And the relapse evidence, well, it's not great. And we're talking about actually those who remain free from medication on a longer term, aripiprazole here versus placebo. So aripiprazole, yes, it's better. That's no question. Okay. I'll come back to the treatment from the Canadian group in a minute, what the recommendations are. But actually, if you look at that time, the number of studies actually looking at psychological interventions was rather limited. There is a Miklovitz who is actually associated with Oxford, came and talked about family-focused treatment for adolescents. And I went to the course and I qualified, as it were, but actually, it's, with respect to David, it is nothing more than a really good clinician would actually do for the patients and their family. So be reassured for that. What you're doing is psychoeducation, clarifying family communication about the illness, which can be very, very difficult, especially if the person's involved in risky behaviors, and especially if it's against the culture of the family or even against the cultural expectations in the neighborhood and religion and so on, things like this. This can really be quite difficult, but those are the things you have to tackle. And it's structured, and it kind of works, because these are the early studies, but I think we'll skip those really. And it's actually depression here. So that's actually, again, that's helpful, because I've just said how much the treatment of depressive episodes are very difficult. But this is the more later, it's 2020, oh, sorry about that. 2020, so it's reasonably up to date. And family-based focused here therapy is showing benefit against enhanced care. Yesterday I talked about Jonathan Green, who did a study looking at treatment as usual versus group treatment for those with self-harm in Manchester, and found out that actually there was no difference, because that treatment as usual in research studies was done properly. What you actually find in practice, your treatment as usual, is unfortunately often rubbish, because the person will come, have the clinic, and then, 6 weeks, next appointment's cancelled, the person's away, dare I say it, on maternity leave or whatever, and things like this. So they never actually get treatment at all, never mind treatment as usual. So good treatment in a good clinic in Turkey will do well. But here, it is clear, even with a defined protocol, that family-focused treatment is actually better. But, as I said, I don't think the family-focused treatment is anything exceptional that you can't deliver. So that's interesting. So the expert levels of evidence, lithium certainly got that, valproate not so much, oxycodone not so much. But some of these other drugs and things like this have FDA approval. Lamotrigine, not so much. But I come back to this group here, and I would suggest that it's worthwhile listening. It's worthwhile reading, just downloading the paper. It's straightforward. First-line treatment for acute mania. Lithium has advantages, but it's quite tricky to treat an acutely manic young person for mania with lithium. So we don't tend to do that, to be honest. We use aripiprazole, actually olanzapine, and risperidone, I think. It's not actually here. Yeah, risperidone. We have risperidone here. So the they call atypical, it should be second generation antipsychotics, I think are, because you're familiar with them, you're familiar with the side effects and things like this. And I think the introduction of lithium takes a little bit of expertise. You have to be, I don't use it for the acute stages, but I think other people can do. But the important thing is to engage the young person in taking this. As I said, psychoeducation is crucial. They have to take responsibility for their own illness, and they may agree at that point, but they may not be competent or have capacity to make that decision. So they could say later on, oh, well, I don't really think I want to take lithium. And one of the most disabling side effects is the shakes. If you get a patient on a normal level of lithium, they often experience, at least initially, shakes. So this is quite difficult if you're writing, especially school students, they have to write a lot or type, and this is a disabling side effect. So the point I'm making is, actually, it may well be that you start someone on an atypical antipsychotic. It's easier, and if it works well, why change? So it may be this, if you have other problems in the longer term, lithium might well be. But practically, I think starting lithium is difficult. So that's for acute management of mania. Oh yeah, I think I have to go back here. There's an underlying caution for this, really. And in fact, in the UK, I don't know whether it's the same in Turkey or Canada, but actually you have to have clear understanding and guidance that you've offered advice about contraception, or someone has offered advice about contraception. You cannot prescribe it otherwise. Basically, the drug company was sued for that. So we do now have guidance, thanks to this group here, about what you should be doing for treatment of depression in bipolar disorder. And sorry about that. Oh, whoops-a-daisy. Sorry about that. Lorazepam. Now, the studies were not necessarily in children and adolescents, but that's extrapolated from adults. But lorazepam does work. Lithium and lamotrigine, a combination there. Olanzapine and fluoxetine, which is one of the things that's nice guidelines actually looked at. And you can use antidepressants. I mean, we might well get some different advice on this from the audience later, I don't know. But if you do use an antidepressant, you've got to be extremely cautious, and you do it with a mood-stabilizing medication in conjunction. This is aripiprazole, combination therapy, and we'll come to the evidence for this as well later. In fact, there's a lot to be said for combination therapy. And we'll come to the evidence for that in a minute. So this is one of the things you may well think, if you've got manic mixed without psychosis, yes, atypical antipsychotics there, or second generation here, but with psychosis here, then antipsychotic is essential. And one of the differential diagnoses I didn't put down on the slide there was differential diagnosis between that in the psychotic spectrum and those with schizophrenia, if we're talking about that diagnosis, because the patients we did in our research study for imaging, the patients who had the highest score on the PANSS and the highest score on the KSADS were those with bipolar disorder. They endorsed all. Thought control, and it was clearly thought control. It wasn't just, yes, I got that. Clearly, the most psychotic patients were those with bipolar disorder. So it's just interesting. The important thing is to actually scurry around and find out the history of the mood instability in the manic episodes. And longitudinal follow-up. Now, stage 4, I discussed at length ECT, but clozapine is recommended in most of the textbooks. Actually, to be honest with you, I would certainly recommend, I'm a great advocate of the use of clozapine. In fact, I'm really a bit dated. Clozapine, lithium, ECT, for me as an older psychiatrist, kind of work. The rest, I'm not so sure. I think you probably ought to blot that out. Just don't take any notice of that. But well, it kind of works. And there's evidence to suggest that, really. But clozapine for bipolar disorder, I haven't used. I wanted to use it, but because all the patients I had problems with ECG, QT interval were too long, so I couldn't use it. But certainly it's recommended, but I just don't personally have that experience. I'm just going to grab a glass of water. Okay. So neuroleptics, we've been through this, but the actions of these drugs are not all the same. Some act on the presynaptic dopamine neuron, and here we get 5-HT inhibiting dopamine release. GABA inhibits the action potential. And here you can see the dopamine D2 antagonist, risperidone and haloperidol, acting on quite a different mechanism here from risperidone, perhaps in clozapine. So your medications are not the same. So that's actually quite interesting. There may be the need for combination of medications. Now, no one wants to, put a patient on a medication, but I'm talking to pharmacologists, people who are interested in pharmacology to come to this conference. It may well be that patients actually benefit from being on 2 medications, or possibly 3, even though that's more complicated. But is there any evidence for this? Well, I'll come to that later. We've done ECT. If you're going to give patients medication, these are the things that NICE guidelines actually recommend, and you should do them. Ready? And this is, as part of the NICE guidelines for patients with schizophrenia, I actually followed the NICE guidelines because I was on the committee. And this was extremely difficult for me as an inpatient consultant. So I started low and went up. It's a complete mistake. I regretted it. It was very, very difficult. But then I'm dealing with the severe end. I think sometimes starting, it's what everyone recommends, but I think if a patient's severely ill, I'd be careful about starting with a low dose or not titrating up very quickly. But these are the titrations. You can use benzodiazepines, and actually I think it's perfectly legitimate to use them. I think I, as a psychiatrist, was brought up in the era where the first few clinics doing adult psychiatry, I had to wean patients off benzodiazepines, so there's antipathy to their use, and that's correct. But actually, in the day-to-day quick service and things like this, please don't disregard the use of benzodiazepines. And it says here, avoid combinations. We're going to look at that. That might be wrong. These are the doses here, but you can get them out of your BNF and clozapine levels here. But there's drug interactions, carbamazepine in particular, fluoxetine also, and valproate, you see there. And lithium increased risk of extrapyramidal side effects, toxicity with clozapine. How long? Well, actually, this is one, if you become a committee member, such as NICE, I'm going on about this now, I had to argue here that 12 weeks was ridiculous. Why would you stop a treatment after 12 weeks? And because NICE said, I'm sorry, there's no evidence beyond 12 weeks, so we've got to, and I say, well, no one's going to treat just for 12 weeks, that's ridiculous. But the NICE guidelines are 12 weeks. And I remember the Royal College of Psychiatrists in Brighton, where I was attending, there were about 200 psychiatrists, and they were all up in arms after 2 talks to say, 12 weeks is ridiculous. And I thought they were going to turn to me as a committee. I was the only child and adolescent psychiatrist on the member board there. So they're going to turn around to me and say, why did you say 12 weeks? Fortunately, someone else put their hands up and asked a different question, and I got away with it. But as a committee member, I'd have to defend it. But there's no great evidence. There's absence of evidence. That's what's the problem. So you guys need to research this area and come up with a better... Yep. And I think here, well, we'll come to, does lithium help suicidal behaviors? What are we doing in terms of time? I probably need to move. Polypharmacy is the order of what's happening here. Now, look at this. This is an important slide. Look at it, because what it's suggesting here is that if you, I think it's from Denmark. No, it's from one of the Scandinavian countries where you get total population coverage as an epidemiological. If you look here, months from initiation of treatment here, and we look at the black one, lithium comes down here like this. This is percentage who actually relapses, typical Kaplan-Meier survival curve here. It doesn't look too good. It's better than the other drugs. But actually what you see here is the combination of medications here are better. Lithium plus valproate plus quetiapine. That's across the population. It's not for child and adolescents, it's across the population. So the point I'm making here is, do not think that if your patient's unstable and they're taking the medication, think the answer is, oh, well, I don't know, just carry on. It may well be a combination of medications, absolutely vital. And I said yesterday, and I do believe this, our colleagues in general medicine are way ahead of us. They never would have treated cancer or HIV if they stuck with one drug combination, one drug. They use combinations, and we need to be much more, I think, aggressive in our treatment and research to show that combinations of medications may be necessary. And I'm sorry, that's the way it pans out for you. Because can you imagine here, if you're a husband and suddenly you go off and spend the family fortune, or a student, you suddenly go off and do this, that, and the other? It's not really funny. So COBE is one of the studies you do need to it's a longitudinal naturalistic study here from the States. A combination of lithium versus other mood stabilizers, OMS, other mood stabilizers. And actually what you look here is that after adjustment, it's a small number, nevertheless it's the best we've got, lithium versus other things, had half as many suicide attempts, fewer depressive symptoms, less psychosocial impairment, and less aggression. So, hey-ho, we got some really positive evidence of the use of lithium versus other mood stabilizers, and actually, Feindling, who I know, has actually done quite a lot here to show the effects of this, the discontinuation. Lithium, actually, if you use that in patients well, is better than discontinuation of placebo. Response there, and not much difference between placebo in terms of weight gain. But this is slightly nuanced here, because Anne Duffy did a study looking at, or a review looking at the response to antipsychotics versus lithium, and I think the evidence that she puts forward is probably in the children, antipsychotics are slightly better. Now, one of the things I think I do tell patients is lithium does reduce aggression, and that's helpful, and it does reduce suicide rates. And actually, there's an appreciable self-harm and suicide rate with bipolar disorder. So actually, any medication that can actually reduce the suicide rate is worth thinking about. This is a study by Andrea Cipriani, who I mentioned yesterday. He's now a professor in psychiatry, and John Geddes, who was head of department, is still professor, but there we are. And actually, what we're looking here, suicides, and overall, there is a benefit here versus olanzapine versus other medications here. So it does versus amitriptyline, yeah. So it's overall, lithium does reduce suicide. And actually, possibly, this is, I'm sorry, it's not labeled very well, I apologize for that, all deaths. So it probably just does that. So actually, increasing lithium actually prevents death. Actually, it's quite an interesting one. My colleague here will probably be able to tell you a little bit more, but actually there's evidence that lithium is anti-cancer as well, but we'll talk about that. So, nice guidelines. How do you identify? You do not do it on questionnaires. You do not do it online. You cannot make that diagnosis. It's a clinical diagnosis. And it should be done by specialists. But are the specialists? Because it's so rare, you don't necessarily pick it up. So actually, you do need someone who's actually done that before. You do need to do intensive monitoring. I told you about the pen and paper, but I've also told you about the use of digital platforms to actually help with that. Tier 4 service, you do need to know that. Mania must be present. And irritability is not a core diagnostic, because irritability goes across a range of diagnostics, and that's the big difference. This is an important caveat. So you've got a person who comes to you with depression and a family history. It may well be important to actually well, it was vital to review that, but you probably just have to review them before making a diagnosis. And I think Nice made an issue here about bipolar 2. I think we probably don't need this. Now, is there anything for the future? Well, lithium works well, but it has many, many side effects. So I phoned up Phil Cowan, who's a professor of psychopharmacology in Oxford, and he said, well, we are developing Epsom. So it's a developing drug. It actually has a inositol depletion action. So that's what it does. And it actually does, in MRI studies, reduce this. And it probably does, it is effective. But at the moment, all he could tell me was that actually when you redo the medication, then actually the patients relapsed and we had had manic episodes. So the evidence for Epsom is not there yet. But just to reassure you that there is research going on to look at this in the future. So Anne Duffy, who I do respect, and she also was attached to Oxford for some while, according to her, and I agree with her, is rare. In fact, Perry was from Australia would say all the studies showed no bipolar disorder in children. It's significantly different, and they're suggesting it's a neurodevelopmental disorder. And she was suggesting younger children antipsychotics over lithium, even though I told you about the effects of lithium in the longer term. I think that's about it. It's a shame I missed one of the slides here. It's unfortunately because my colleague, Christoph Stenhausen, who is German from Zurich, actually professor, it was in Denmark, and he did an epidemiological survey. And actually, I do apologize for not having the slide here, but he goes through all the epidemiological evidence for children and adolescents in Denmark. Eating disorders, schizophrenia, so on, so on, so on, so on, so on. Not a mention of bipolar disorder. Not even there. Thank you. So we have about 5 minutes for questions before prayer.
Yes, thank you, Professor, for your brief and very, you used very nice timetable. So we have, I think we can take 2 or 3 questions from the, okay. Yes, Professor Greenshaw, please.
Tony, thank you very much for a really excellent lecture. I think you provided a really thorough and deep review of the pros and cons of different guidelines and the problems related to treating mania and depression. One question that might be in the minds of young clinicians in the audience is, given the guidelines and given the priority for lithium use, and your comments about really needing some experience to use lithium properly, would you recommend they go for lithium, consult with senior colleagues, or go for another alternate first and bring in lithium as a second line?
I'll come to you because I can't hear through this. I'm terribly, terribly sorry,
Okay.
but I can speak and it's fine. I'm sorry, I couldn't hear very.
No problem. The question is, you talked about the difficulties of using lithium.
Yes.
As a first-line response. And for young clinicians in the audience, given the guidelines and the recommendation on lithium, from a practical point of view, would you recommend consulting with a senior colleague and going with lithium, or going with lithium as a second-line treatment?
I think, to be honest, I think practically it's probably best to go second line. I really think so. And because it's important to get the engagement of the young person and the family. And I do think those side effects from lithium are quite important. But I think bipolar disorder is such a severe problem, and then lithium is really very good mood stabilizer. It's the best. That's crystal clear. So it's worth persevering with that. So I tend to not use it first of all.
If I could make one more point.
Oh, that's fine.
You talked about, the psychoeducation perspective, and you mentioned that a psychiatrist is doing a really good job who's
Yes.
competent will do that
Yes.
anyway. But in the system, as we know, there's limited time for psychiatry interactions
Yeah,
with the patient and family members.
Mm.
So do you have any advice for the young psychiatrists in the room about how to approach that and get the balance right in terms of the time investment?
In the ward situation, I think we have what is known as healthcare assistants in the UK. And they're completely undervalued. Usually the psychology graduates and so on, they're completely articulate, completely enthusiastic. And we know the evidence that actually younger, inexperienced psychotherapists are the best. And it's true. You can educate them to do the work. And it works like a dream because they're younger, the person makes immediate contact and things like that. And if they don't know something, they'll come to you. And I think actually in the ward situation, using healthcare assistance and things like this is an absolute fantastic winner. It's a winner all the way around. I think in the clinics, I think it's probably you can use a whole combination of things. Website, and self-help groups and things like that, I think, is very useful too. But I think if you have, it doesn't have to be done by a doctor. As long as a doctor endorses that and you get the feedback, so I don't know the answer to this, I'll go and ask Dr. So-and-so and so-and-so. And I think the family really respect that. Because you're quite right, it's actually having the time and tailoring things to the individual. You know, that's very important. The big thing, of course, is compliance with medication. And I think that's a skill to say to someone, I didn't take the medication, but I don't think becoming censorious or telling them off is actually quite helpful. I think it's, which everyone knows, but I'm just saying it for the record, really. I think actually being supportive and trying to put yourself in their shoes. Would you like to be a 17-year-old on lithium? Not a good idea. And I also state right from the beginning, for a young girl, I say, you will have to think about this when you want to become pregnant. And even if she's 17, because what I'm also signaling by that is this is a long-term problem, and you cannot, even though you're 17, say, oh, I'm not having a child now. And it may not be that she's not going to have a child for another 10 years or so, but she needs to know. Thank you.
Okay. Dr. Hakan will ask the second question. Okay.
Dear Professor, thank you so much for your attendance and for this great presentation. And as you said, aripiprazole seems effective in these clinical trials, but it's not effective in real practice. What do you prefer to start treatment for acute mania in your clinical practice?
Could you translate that question? I couldn't hear it.
I'm
very sorry. The translator is very, very good, but it's just me not hearing. Huh? Okay, great. Well, I'll come down to you then. I'm sorry about this.
Yeah, thank you so much, Professor. As you said that the aripiprazole trials showed that it's effective, but in real practice it's not effective too much. And what do you prefer to start in your clinical practice for acute mania?
Treatment of what?
Drug treatment.
Treatment of?
Acute mania.
Well, I think it's important to use several things, really, first and foremost. I think it's absolutely important in the ward situation, as I said, to have things quiet and, as possible, least stimulating. And I think that goes tremendous way. You're really swimming against the tide if you've got a busy and noisy ward. So that's one thing. And atypical antipsychotics, I would use risperidone first and foremost, really. Perhaps olanzapine if you need sedation as well. So that's fine. I think there's a worry about using olanzapine in the first instance because of the weight gain and so on things. But in acute mania, you have a very difficult situation. I think it's akin to like a fire taking place. You really need to get on top of it as soon as possible. I would defer to my colleagues, perhaps, who has more experience of that in adults. But I do think it's like a fire, incendiary. So you do need to make sure you get on top of things as quickly as possible. That's why in this particular situation, go low, go slow, and all the rest of it is completely wrong advice, I think. You don't have to go really heavy-handed, but I would certainly use experienced team, I think, really.
Okay. Any questions? Yes.
Thank you so much, Professor. I want to ask about...
Yeah, okay, I'll come to you. Sorry about that.
Yeah. I want to ask about treatment resistance bipolar. If we use clozapine and EKT, what do you recommend for us?
Clozapine and?
EKT.
ACT.
Well, as I said, I don't have that much experience in using clozapine as a first-line treatment. I don't know, do you? No, I don't. But it's on the guidelines there. The indications, I think, for ECT is when you've got a combination of medication. You've got a benzodiazepine, you've got a olanzapine, you've got risperidone, lithium, as you say, from an adult colleague who has more experience than that. And I go to Professor Phil Cowan, and he says, ECT. Because they have that much more knowledge and experience of that, as a child adolescent psychiatrist, you can never accumulate that knowledge. You might as well go to your colleagues next door, have a good colleague, and say, what do I do next? And Phil just turns around and said, ECT. And so
we used ECT and also her resistance ECT.
Yeah, I think the question you're asking is really, if I understood it correctly, use ECT, that stabilizes that, but that you still need to continue a mood stabilizer. So this would be a patient coming down, you'd introduce into the idea of using lithium in the longer term and things like that. But I do emphasize the need for making sure things are stable, quiet, and stable. If you haven't got an area in your ward, you're really, really doing yourself a disservice. I hope that answers your question.
Thank you so much.
I think we have to finish now for prayers, don't we?
Thank you very much, Dr. James. We can leave it here. So as they say, less is more. It seems shorter talks provoking more questions. So lesson to take home. And thank you a lot.